covering today. We're recording. Thank you. So I'll have an announcement, then we'll do some introductions. And we have a guest speaker with us today, Kelly Volkman. So I'll introduce her in a little while. And then I have a little bit of information about some training opportunities. We'll go on and hear from Kim Emery from Columbia County, and she's going to share about their community health worker and what they do in a day. We have some time for question, answer, and an evaluation at the end. Okay, so my announcement is just that we had an amended contract that was sent out on February 9th. There was some language that had to be changed, I think, around it had said subrecipient in some areas, and it needs to say subcontractor. So that had been updated, and then the contracts were sent out to everyone on the 9th. We've been able to get a couple back from Garfield Community and Yakima Neighborhood, but if you guys, I want to make sure you're aware so you can speak with your signatories and have them get those contracts approved or signed and back to Heidi Hill at Greater Health Now. And I have Heidi's email there if you have a question. So that was just a quick announcement. And I don't know if you all were aware of that. Do you have any questions about that for me at the moment? Okay, well, let's go on and we'll go around the room and do some introductions. So be thinking, because I want us thinking positive today. What is a specific part of your job that you enjoy? So say your name, your organization, and then something about your job that you enjoy. Would love to hear from you guys. So I will start with my name. I'm Laurel. My organization is I'm contracting with the Greater Health Now, and the part of my job that I enjoy is really when I get to do in-person visits and see your faces and see how you're set up in your clinics and get to have that in-person introduction. I really enjoy that. So we will go right around the room and get going. So I will start with Kelly before her introduction, if you don't mind, Kelly. You want to join us on the sharing?
Sure. Hello, everyone. My name is Kelly Volkman, and I'm the project director of the Community Health Worker Institute for Northwest Regional Primary Care Association. And this part that I love the most in my job is I get to interact with community health workers, if not on a daily basis, then on a weekly basis through trainings, etc. And I just absolutely love that. So, Laurel, do you want to choose the next one, or should I just popcorn it?
Yeah, go ahead, and that would be great. Go ahead and choose this. Okay. Thanks, Kelly.
I'll pass it on to Brian.
Hello, my name is Brian Delano. I'm a community hub liaison for Greater Health Now, and I'm excited about this because I was in my past a community health worker. So that is part of what is still the favorite part of my job, is building connections and relationships and being with the people. So I still get to do that as a community hub liaison. And so those skills got to transfer, and that's what I enjoy about my job. And I will go with Anna.
Thanks, Brian. Hi, I'm Anna. I'm with Greater Health Now. I am the Senior Director of Transformational Health Integration. And what I love about my job is getting to be a part of events like this, where it really is looking at how do we transform our healthcare delivery system. So really happy to be here. And I will pass it on to Michelle Sullivan.
Thank you, Anna. I'm Michelle Sullivan. I'm with Yakima Neighborhood Health Services. I'm the Chief Quality and Compliance Officer here. And I think the favorite part of my job is fostering growth in others, whether those be my colleagues or my clients. And I will send it to Stacy George.
Hi, good afternoon, everyone. My name is Stacy George. I'm the Director for Quality, Population Health, and Utilization Review for Community Health of Central Washington in Yakima, Washington. And I love lots of parts of my job, but what I really love hearing is when I get to meet with our staff, our nurse care coordinators and our social workers, and they tell me these amazing success stories and connections that they've had with their patients. Sometimes being at like a higher level, you don't always feel that how impactful your work is, but I love hearing those because I love knowing the difference we make in our patients' lives. Oh, sorry. And I will pick Nicole Matthews. Did you already go?
I did not. Present, here I am. Nicole Matthews, Greater Health Now. I'm the Director of Innovation and Health Integration. And what I absolutely love, if anybody knows anything or has ever met me before, I just am a social butterfly. I like to hear from new people. I like to hear what people are doing, and it's nice because everything ties into everything we're doing. I was very fortunate I got to see Laurel in person the other day, and I just love hearing about the stuff that she's working on and some of the really awesome success stories of what she's been working on this last couple months and years in life, and it's just really great to meet people. Boom, okay, let's see it. Ashley, did we get to Ashley yet?
Okay, Ashley.
At Palouse. Oh, okay. Well,
She'll come on. Let's see. Hey, Ashley, are you there?
she doesn't have a mic. I can pass it to someone I do know. I see Kim Sulzler on there. I definitely know Kim.
All right.
Hi, Nicole.
Hey, Kim.
Nice to see you again.
I'm like a cockroach. I just like don't go away.
I'm Kim Salzer. I'm the clinic manager for Community Health of Central Washington in Ellensburg. I work with Stacy. And everybody has said all the reasons that I love my job. I love helping, as the manager of the clinic, helping providers help patients. And how about Leanna? Did she go?
Leanna?
So Leanna Reynoso, I'm from Cadillac. And I was gonna say what Stacy said, but so I'll say something different. I love everything about my job, but I definitely like that we are able to get patients to where they need the help. Just being able to, we have so many just different departments and be able to help them ease their way and get the help that they need. I did join a little late, so I'm not sure who all has gotten to go.
We can go on to, it says M. Baden, but that's Marcia. So we'll go on to Marcia next. Thank you, Leanna.
Looks like Marcia said in the chat she may not be able to answer. She's in clinic.
Oh, gotcha. Thank you for helping with the chat. And then the other, we just missed Palouse, right? Are you guys all in one room? I don't know if they're chatting. Usually when I talk to them, they're all in one office, so we'll catch them. Yesenia, I don't think we heard from you.
Hi, everyone. My name is Yesenia or Yesi, and I'm a health equity coordinator here at Cadillac. And something that I enjoy, I like everything. I love my job, but one of the things that I love is to be able to be part of the change. I know healthcare is changing and health equity is so new, and there's so many initiatives going on in different areas, different organizations, and I love to be part of something new, that it's something good for everyone in our communities and generations to come. So I'm excited to be here.
Thank you. So we're just, I think, Mike, we didn't hear from you. If you wouldn't mind coming on.
Hi, Mike Vachon with Yakima Neighborhood Health Services. One of the favorite parts of my job is that I get to transfer data so that it's meaningful and actionable to people that can actually benefit from it, use it for either policy, programs, or patient care.
Thank you, Mike. Appreciate it. thank you everyone who spoke up, and I'll find you guys later, the Palouse people, and because we'd love to hear from you, question and answer or comments later on. So I'm gonna go ahead and move forward and introduce Kelly. So I'm so excited to have Kelly here. As she mentioned just a moment ago, she's the director of the Community Health Worker Institute for the Northwest Regional Primary Care Association. Kelly is committed to advancing and advocating for community health worker programs in primary care. Kelly has rich experience providing patient care as a registered nurse and program manager for a robust team of community health workers in an Oregon FQHC. Kelly has a deep appreciation for the unique qualities, as she shared, and value of community health workers that they bring to the healthcare systems, and the importance of building sustainable programs to support them. So I'm so pleased to be able to have Kelly here today, and I thank you so much, Kelly, for being willing to present on short notice. So I'm going to go ahead and stop sharing so that Kelly can share her screen. And welcome. Thank you, Kelly.
Thank you. It's a pleasure for me to get to do this. I pull my stuff up here. Are you able to see everything there?
Yes.
Okay, just gotta rearrange everything here. So again, my name's Kelly, and we're going to talk about bringing community health workers into primary care, which is one of my passions. So I know that many of you, or probably all of you, are familiar with community health workers, but just to give us some of the same language talking points, the most important thing is that they are trusted members of the community being served. That doesn't mean that they necessarily have to be from that community, but they need to have some commonality with the community, whether that is language, culture, socioeconomic status. Often it can be a disease state, whether it's someone who's living with diabetes working with other folks who are living with diabetes. It could be a mental health consumer. Here in Oregon, which is where I live and I work in Oregon, even though my company's in Seattle. In Oregon, we have the traditional health worker umbrella term, and underneath that, our community health workers are peer support and peer wellness. And that particular worker type are folks who have self-identified as basically community health workers who are living with mental health concerns. So it could be many things that make up a community health worker, but above all, it's someone who looks like me, speaks like me, and knows my strengths and understands me. Especially for me, that piece about knowing my strengths, community health workers often will come from that strength-based perspective and not looking at me as a problem. And that is something that I really appreciate about community health workers. And so this is a quote. We try to ground our work at the SHW Institute in community health workers. We often have them present with us when possible. And these are some quotes from some of the community health workers that we've worked with. I don't feel that community health worker is a job title, and there's no one job description necessarily, and you can call them whatever you want to, but they have to have the heart of a health worker. And the one on the bottom, promotores de salud nacen, no se hacen, which means that they're born, they're not made. And when I was the manager of the community health worker team here in Benton County, and I hired many, at one point our team was 27 community health workers strong. And over the 13 years that I worked there, I hired many CHWs, and I never once really looked at what their job experience was, but I always looked at who they were and what their life experience brought, what they said that they cared about. That was what was most important to me, because I can teach the skills that they need to be a CHW, but I couldn't teach who they were. So as you'll see as we go forward, I'm super visual, and I really have to have a picture to tell me anything to help me grasp things. Laurel, I tend to go on and on, so please stop me when a hard stop when I'm at time.
I am so enjoying it, Kelly. It's going to be hard pressed for me to stop, but if you run terribly over, I will stop.
Okay.
You.
I can talk about this all day long, so make sure. So for me, it was helpful to think about, especially as our team grew, to think about this continuum of services that CHWs can operate on. They're in the community, but they can also be integrated into clinic settings, and that's where my heart lies. I'm an RN. I practice, my license continues to be in California, but I practiced here in Oregon. And so for me to seeing that clinical base, but also I have an MPH, so Master's in Public Health. So really being able to combine the two, public health and clinic in one workforce was eye-opening for me and really was the missing piece that I could see that medical services and healthcare really needed. So as far as I'm concerned, CHWs are that linchpin or that integral member of the workforce that really brings it all together. The diagram at the bottom, you can see that kind of continuum there. I love rainbows, so I had to put that in there. From primary care on the left, going through that healthcare services access and utilization, through social service and resource connection. And that can also be that signing people up for healthcare or for Medicaid services. Through the community, school, and church. At one point on my team, we had 3 of our community health workers who were embedded in school systems, and that was very useful to help connect children and their families into our CHC system. And then we had one CHW who was really into the advocacy, policy, and systems change. And we had her stationed at different places in our community where she was able to work on that. For example, Parks and Rec, and she did a lot of policy work around how services were extended to our Latino community, whether things were in Spanish or not. We had lots of places when she started there that did not have services in Spanish or had resources in Spanish, so she was really able to make some policy changes. So community roles for CHWs are more known, I think, more familiar. CHWs have been in our healthcare systems or public health systems for decades and decades and centuries in some other countries. And they often are looking at that connection between the community and social service resources, and then that connection maybe to the outside walls of the clinic. Really looking at barrier busting, cultural mediation between communities and the systems of care. And they are excellent and expert at that. I think there are very few other workforce members who are as skilled at connecting with social service resources in those culturally and language specific and affirming ways that CHWs can do that. And then bringing them into the clinical role is a little bit of a newer practice. Certainly 13 years ago when we first started, 15 years ago now, it was a very new system. I learned about it first at what was now One Community Health. At the time, it was La Clínica del Cariño in Hood River. And they had a promotora program that was embedded in their clinic. And it was the first time I'd ever seen that. It had grown organically. I was there to do an evaluation of it. And I fell in love with the model. And when I was first hired to work at our community health centers here in Corvallis, Oregon, I had to bring it with me because it was so amazing. But I always want to make sure that I give credit to them because they're the ones that taught me how to do this in the best possible way. The thing that I like the best about it is that that community health worker can bridge the gap and bring that community patient perspective into the care team itself in that, again, linguistic and culturally specific and sensitive way. And this is a diagram that I came up with to really help us see that in order for a clinically based community health worker, which seems a little bit like an oxymoron, to be successful, they really have to have one foot in the clinic and one foot in the community. If you take a community health worker and you bring them into the clinic, community health workers have said to me they get sucked in to the clinic, then they lose that connection to the community, and that is vitally important. And so really being able to allow that CHW, if they're in your primary care setting, to have the time that they need in the clinic, whether that's every day outside working with their clients or maybe having the freedom to work with them outside of the clinic hours or doing events out in the community, whatever it is that allows them to keep that established connection there. And then always remembering that no matter what role they play, most important word in the title community health worker, it's not health, it's community. And that's what really sustains them and why they are so incredibly valuable. And then that question comes, why would you integrate a CHW into that primary care setting? I'm really glad you asked that, even though I asked that. I'm glad to ask it on your behalf, because they can be and should be, in my perspective, an integral member of that person-centered care team. When in Oregon, we call our person-centered care teams or our medical homes, patient-centered primary care home, because in Oregon, we like to do things differently. We have to call them all different things. I'm not sure why. And so I was lucky enough to be in one of the early adopters of this model. And so on our care teams, we had every one of these little petals. We had all of these different roles. And we had community health workers who were truly integrated in. They were part and parcel of a valuable member of that care team, which I really loved. If you're not familiar with the quintuple aim, this was brought from the triple aim, which then became the quadruple aim. And then maybe last year, the year before, they brought out that health equity piece. And now it's the quintuple or the quintuple aim. And I feel very strongly that CHWs can help your organization, your CHC, really make this a reality, make it more than just talking words on a page. And the way that they help do that is by improving staff experience. We all know that the only reason we work in primary care, especially in our CHC settings, is not for the money, because the money is not there. We don't make huge salaries. We do it for the mission. We're there because we care about our clients, we care about our communities. And we also know that it's frustrating as staff members to know that there's only so many resources we can give, because the resources often aren't there and we don't have time. But knowing that you can see your clients and then hand them warm hand off to a CHW who can take care of all or many of their social determinant needs that we can't do maybe in the clinic, is a huge burden off of our chest and weight off of our shoulders, which really enhances that staff experience. They also can improve communication by being that bridge of trust and really involving the team and the patients and their families in creating that care plan that is easy to adhere to, makes it much more meaningful, and again, improve patient outcome. For advancing health equity, anytime that you can bring a program in that is more linguistically, socially, culturally specific, you're going to have that increase in health equity. This is interesting, those ROI studies, people keep saying, well, what's the value of CHWs? And shouldn't we have to be able to prove their value? And actually we don't, because there have been innumerable studies at this point about the value and the ROI of CHWs. I've seen up to $3 per investment back. I've actually seen more. So it's not something that we have to keep proving. And then there's proven health outcomes, especially when you are in a clinic setting, teaching your CHWs, giving them the proper training to deliver chronic disease support and self-management. In our clinic, we did that, and they were amazing at it. They worked with our diabetes sub-educators and our RNs, and they had a huge role to play. We saw patients going from an A1C of 11 down to 6.5, just within 6 to 8 months of working with our CHWs. It was incredible, the difference that they were able to accomplish. And then during the pandemic, we've all heard the amazing work that they did. Michelle Sullivan and I worked on a project together where we had a lot of work with CHWs out in the fields during the pandemic. And then that comes to my question, which I just asked: why do we still have to justify CHW programs? And yet we do, because the money's not there. Laurel, how am I doing on time? Got just a few minutes? Okay, so I'm going to just talk really briefly. This could be another hour and a half on its own, but we'll just talk really briefly about how ways to support and sustain CHW programs. I was very creative and very innovative in supporting my programs, because there's no quick fix. There's no magic bullet. If there was, I would definitely buy into that. There are a few creative funding scenarios. One is Medicaid reimbursement, which I know is really being worked on in Washington. At many different levels, state on down. There's blending and braiding of funding streams, whether that's through grants, through state RAP funds and Medicaid RAP funds, or what we call CURF here in Oregon, which is County Unrestricted Funding, and then contracts. So they all many different ways to blend and braid those funding streams. We'll talk about what that means. And then making the case for your CHW program. We're not going to go over that today because there's just so many ways to do that, and that's quite a lengthy discussion. But that could be a discussion for another day. So Medicaid reimbursement, yes, that is one good strategy. It's a way to pay partially for CHW services. It's not a bullet, and it may create a path forward for sustainability. There is no national model for this. No one, it's a state by state, and it has a lot to do with Medicaid waivers. And I know that Washington has their waiver, and I think they're in either the first or the second year of that. In Oregon, we're doing Medicaid 3.0, so we're pretty far down that path. And as of 7/22, and I've looked to see if there's any update, and I haven't found one yet, there are 29 states that allow Medicaid payment for CHW services. However, it's not a magic bullet, and current reimbursement totals right now are not going to fully sustain a program, especially if you are paying your CHW a living wage and benefits, which they should be. They should absolutely be paid according to the work that they're doing. Your CHW is probably going to need approved training or certification for those services in order to be reimbursable, which is a whole discussion and kind of a ball of wax, according in and of itself. There are some states there are some states that don't want to go down that path. Some are mixed and balanced. I know in Washington, you've got advocates on both sides of that. In Oregon, we went early on towards that. I was lucky enough to be part of those initial discussions, and they were lively. Let me just put it that way. They were very lively. And we did go down the path towards certification. You don't have to have a certification in order to work as a CHW in Oregon, but you have to have one if you're going to be working for an agency that bills Medicaid. So the two of those are tied together. However, you're only reimbursable for those Medicaid patients. So for many CHWs, they're not going to go out and just work with Medicaid patients. They're going to work with the entire community. So it can be exclusionary in that. And then the need for certification may exclude some of our most valuable grassroots CHWs who may not have the documentation status to be working in agencies that would be otherwise able to hire them. So it can be a two-edged sword. And then CMS reimbursement really should just be one thread of a funding strategy for all of these different reasons. So if you're not familiar with the term blending and braiding, it's a very useful strategy. So blending means you're taking different funding sources and you're putting them into a pool. And you can use that pool of funding to support your program in any way that you need to. For me, I did this extensively. It's much easier than braiding, which we'll talk about in a moment. But I had so many different sources of funding that supported my different workers and my different programs. Putting them all into a pool means that I can pull that money and support whoever I need to in any way and in any amount. So maybe 2.50 FTE over here, 0.5 FTE over there, without having to track it. And so that was really useful. Braiding is different. It's the same idea where you're using different funding sources, but they can't go into their own combined pool. They have to stay in their separate streams. So I had a number of these sources as well. It's mostly grant funding. So that meant that I could use 0.25 and 0.5 of those same streams, but I had to keep them separate. And I had to do that reporting at the end of every month. I had to say who I was supporting, how much, and what they did. So I really had to keep, if I was supporting one person with 3 different funding streams, I had to make sure that 0.25 of that funding of that person's time went towards those activities. So I couldn't just mix them all up. It was much harder to account for. My CFO did not love me, neither did my accounting systems, because they really had to do a lot of tracking. It was worth it, and I didn't really care too much about how they felt, although I mean, I tried my best to satisfy them, and it was a lot of data that I had to do, but it was worth it. So we talked about Medicaid reimbursement, blending and braiding, and like I said before, making the case is how it benefits patients and care team, making that quintuple aim. There's lots more we could talk about that, how it improves population management, which is near and dear to my heart. CHW is working with your population management folks is amazing. It can make a huge difference. And then making sure that you meet your metrics that goes along with population health. Super valuable. But that's another topic for another day, and I'm going to turn it back to Laurel. If you have any questions, please get in touch with Laurel. She can get those to me. I'm happy to talk about this. I know at the end I'll stick around and we can, if you have any questions, just let me know.
Thank you so much, Kelly. That was just a great overview, and I bet you there's a bunch of questions out there right now. We will keep moving for now. I had a couple of other things that I wanted to talk about as far as training that is available. So we'll go ahead if I can get my. So I wanted to talk about training opportunities for community health workers, and I would assume that most of you are aware that the Department of Health has the community health worker core competency training. But I'll just briefly give an overview of that, and then I've just given the link at the bottom, and they have listed the specific times and places that the core competency training is available. Just an overview, it's 2 to 4 hours a week for over 8 weeks. It's in person for the first and the last training. It's free. The other trainings are online. And they're offered in English and Spanish. And then there's also the health specific modules. Those are online and they're free. They're really good topics on those. Immunization across the lifespan. I'll just give a few examples because there's like a lot of different ones. Memory loss and dementia, depression, anxiety, helping others cope, cardiovascular health, providing social support, improving asthma outcomes, pre-diabetes and diabetes, conducting food insecurity screening. A lot of these topics are great and it's good information. And it's important to reiterate, this doesn't give them a certification. We don't even have that in the works at all at this point in our state. But it does give them an ability to say, I've completed this training, and organizations individually can make a decision what their requirements are. If they would like for the community health workers that they hire and have work for them to complete this training. I did talk with Michelle, and I don't know how to pronounce her last name, but at the Department of Health, and she said the trainings you need to, like, especially for the core competency training, you need to go on and register like a month and a half in advance. Right as we checked earlier this week, I think she said there were 64 people enrolled for the next one coming up in Richland on April 11th, and they could go potentially up to 124. So, it's out there and available. And so we can direct people to their website and to those training classes that are available. So any questions on that I might be able to help with? Okay, another type of training is there's a Camden Coalition and I'll just kind of read from the slide here. I don't know if people have heard of it. A multidisciplinary community-based nonprofit working to improve care for people with complex health and social needs in Camden in New Jersey. But they develop and test care management models and redesign systems in partnership with consumers, community members, health systems, community-based organizations, government agencies, payers, and more. So there's a model that they have and that you can participate in and get a complex care certificate. So there's 30 competencies, and this is basically from their website. These competencies are, I'll give you an idea of what's covered on the next slide. But the training is intended for all members of the team, so it would include CHWs, nurses, doctors, peers, social workers, case managers, and so there's CEUs available for taking part in the training. And so this kind of shows the courses that are part of the training. So just FYI, I don't want to spend that much time on it because I know you guys can go look it up and find out more information, but I wanted you to know about it. And I wanted to segue a little bit to Anna from Greater Health Now. who is going to share with us about an opportunity in regards to the Camden Coalition complex care coursework.
Thanks, Laurel. Yes, the ACHs have an association that they're looking at how do we maximize and pool resources. And one of the things this collective has chosen to do is purchase licenses for the Camden course. And we will be kind of parceling those out among the partner ACHs and being able to provide trainings. The course itself is a little expensive. It's $500. So we realize this is such a rich resource that GHN will be developing a process just to help pay for that. We're not quite sure exactly how many we're going to be able to parcel out, roughly 80, we think, but more to be revealed.
Great, thanks, Anna. We just wanted to get the information out there so that people could know of it and be thinking of it and consider that in with other options that are out there and available for you with your community health worker trainings. Okay, so again, I'm going to switch and we are going to, I'm very happy Kim popped in here a little bit late with us. But I want to introduce Kim Emery, and she is from the Columbia County Healthcare. Kim's a PA, and she's currently the Director of Clinical Services for Columbia County's 2 rural health clinics, dental clinic, and the fee-for-service clinic in College Place. Kim has a rich and varied history of experience in healthcare, including 20 years as a laboratory medical technologist in Bremerton and 14 years as a PA in the University of Washington Neighborhood Clinics. And recently, she has been working in Dayton, but she was caring for patients in the clinic, ER, and nursing home in Dayton. And now she's going to share with us about Columbia County's community health worker and how they function as part of the team out there in Columbia County. So I'm excited to have Kim share, and it's fun to hear what they've done, because some of the things that Kelly just talked about, you know, trying to figure out the funding and how to keep this going because of the many needs that they have in their rural health community. So with that, I will turn it over to you, Kim.
Hello, everybody. I don't have fancy slides, so you're just going to have to listen to me talk today. So I'm very happy to be part of the Columbia County Health System. I came here in 2012 and did patient care forever. And to be honest, I still sneak and see some patients from time to time if somebody's sick, and that is, to me, wonderful. But we have some really great programs to be such a little bitty place and a little town. I originally come from Memphis, so I know about cities, and something this small is really wonderful to me, but was a learning curve. So in our little hospital system, we do have these clinics, but we also have this huge population health program. And so that includes an outpatient palliative care program, chronic care management, which is mainly phones, Partners Improving Patient Health, which is a HRSA grant that we have to go out and take care of people who have cardiovascular disease and COPD. And so this team works together. We also have a diabetic educator who often goes into the homes, and we take care of people's feet for all their nail issues in conjunction with aging and long-term care. So we have this huge population health program mainly devoted to our oldsters, but we are a very aging community. So you have that. And as part of this, we have a community health worker. And we are very pleased because our community health worker that we have right now also has his master's in social work. So that gives him a little broader scope than somebody else may have. We have somebody who right now is a CNA and is helping us do home visits. And then she was going to get her community health worker so she could do a little bit more. I looked at our job descriptions to see what all we expect, because we know that this is a fluid area. This is not, I just did my job and then I went home, and I'm going to give you a little bit of examples. But we have things like identifying and contacting patients, establishing a trusting relationship, going out to the home and assessing and screening those important social determinants of health, because we have people, do they have any food? Do they have plumbing in their house? Are they hoarders? What do they need help with? Because when you see somebody in the clinic, you see what they want you to see and you see what they present to you. But then when you are invited, because we need to always be invited to go into their home, then you go, I don't know how you didn't fall through the floor. We need to find our community resources. How can we build a ramp for your wheelchair? How can we fix the floor so you won't fall through? How can we get somebody to help clean up because you were sick for 6 months? Nobody knew that. And you have 5 cats and 3 dogs and nobody has cleaned up after the animals. There's just all kinds of things that we find that we need to be able to do. Our community health workers know who to go to help. How do you get people on insurance? What do you have to fill out if you really need to be on disability? How do you get a place to stay while the floor is being fixed in your house? And so they know all the places to go and they help. And our palliative care program is under one of our nurse practitioners who is our population health champion. And so all of this flows under all the things that she does. So I wanted to have our community health worker come and talk to us to share, but of course, that's not what today happened. He has something that he has to be at. So I'm going to try to share a day in the life, because to really understand the position, I think it's crucial to understand those of us who come to work and have our tasks that we do and then go home. This is not quite how this always works out. And we also have our community health worker helping with our ER patients. He helps with inpatients that are going to need to go home, which actually come to the clinic. So, we're all together. This is blended everything in my opinion. So here's an example of one of the cases he had. So he had a pediatrician that asked him to make sure that one of her patients makes it to Children's Hospital in Seattle, which is, as we know, like 300 miles away, for their quarterly oncology follow-up, as they missed the prior 2 follow-ups, which means this poor little person who needs to see oncology has not been to oncology in 9 months. And so people to people were called, but that didn't work because they didn't have the right insurance. And so we also have a transportation department at our facility that we fund through whatever kind of funding you want to call it. We do call it often braided, but it's not the real true definition that I just saw of braided. We just mean somehow we'll find money in one of our pots to make sure this works. So people to people did give us some gas money. And then the community health worker was able to make sure that we got transportation so this little could go and see the people that they needed to see. Of note, the community health worker has worked with this family and they've gotten medical equipment from the Knights of Columbus in Pasco, Walla Walla, because they needed some durable medical equipment. Walla Walla Developmental Disabilities Network has worked with them for some things that they wanted. Our public health has worked with them. Project Timothy, which is a local charity, has worked for them. And Consumer Direct Care Washington has helped to get them in-home caregiver resources. So the community health worker has their feelers out and knows all these different people and all these different agencies, so we can go, what paperwork do we need to get? Does the provider need to fill out any forms? There need to be a referral? What do we do so that we can take care of this family? And you can see that's not like, oh, that spent 10 minutes. No, this is hours and hours of work. Case number 2, we had a patient that was going to have the services of DSHS terminated because they didn't respond to letters and they didn't respond to phone calls. And we know that happens in our community a lot. We'll get people in with a specialist. The specialist's office calls to make an appointment and the patient goes, I didn't know that phone number, so I wouldn't answer. So we have issues there. So this community health worker went to the home and then he found out that the patient actually needed to have 911 call to get an ambulance because they needed to go to the hospital. They were later transferred to Tri-Cities and then they later had toe amputations. What we didn't know at the beginning and we found out is there are a bunch of children at home. now by themselves who are afraid to answer the door. So the community health worker left notes on the door. He called, he tried to call them, and eventually they felt comfortable enough that they did answer the door so that he could help them. As he said, they stopped hiding and he was able to communicate with them. And there was an ex-spouse taking care of them, but then he could help. Do they have food? Do they have electricity? You know, those kind of things. And so that's just by knowing that we need to get his insurance not to be terminated, and look at what all happened from that. We have another case that somebody needed to come to the hospital. So of course, you know, we never want to bother anybody. We didn't want to call 911. He didn't want to do this. So he called his friend, and his friend, we have an emergency entrance and then we have the main entrance. And his friend dropped him off at the main entrance, and there he sat on the bench because he was too far for anybody to see him. But he didn't have the strength to get up and make it to the door by himself. So he called our community health worker and said, I'm outside the hospital. I need to go to the emergency room. Can you help me? So we got that taken care of. So you can see all kinds of things that happen. There was a young man who took care of his grandparents. They died. He didn't have any health care. We got to enroll him into Medicaid. He didn't know how to find a doctor. We found him a PCP in our clinic. His home was basically falling apart, and he was working as a dishwasher, but then his toe became infected. He found out he had diabetes. Of course, he needed amputations, and we were able to get our diabetic educator involved. We were able to get him an actual home that wasn't falling down. He went to the library for the first time in his life and got a library card, so he gets to, you know, use his mind. And so these are the kind of things that we do that are not always, let me go and let me fill out your paperwork. Thank you, goodbye. It is like, first we need to get to know you. This community health worker spent probably on one patient, he's probably spent 6 hours on many different days listening to music until the patient was comfortable enough to say, this is what I need, this is what's going on with me, because you have to develop that rapport. And you know, most of us don't have instant rapport with people. Sometimes you do, but not always. And so we can go on and on. And so time is not hard scheduled for their days, because as we know, the best laid plans, some of these things might take 2 hours to do. Some of these things may take 15 minutes to do. Some of these things take days, because you have to go day and day and day until you get things done. So we say fluidity is the name of the game. We do have him document because we need to know what's going on, but we also try to tailor the needs of the patient with the strengths of the community health worker. In the past, who's retired now, we've had a community health worker, and in his past life, he was a drug and alcohol counselor, and he was also a driver for our transportation. So as you can imagine, he did a lot of counseling, and we tried to put patients together that were very pertinent. And so there was a lot of like, you know, you get a lot of bang for your buck when you get to have counseling. You go, maybe I'm not going to use, you know, how can you help me? And those kind of things. Recently, I spoke to a community health worker from New York State who worked specifically in the emergency department, helping to help not have so many, as we call them, frequent flyers, because often that's just like, I don't know what else to do, so I just go to the ER. Or I'm lonely, I just go to the ER. And in her year that she did that, she was able to decrease the, as we call them, frequent flyers by 20%, which is huge. That's just huge. The community health workers, I have a grant for pediatric and adolescent behavioral health integration, and my mentor place in Tacoma, they use community health workers to follow up and go to the home and go, were you able to get the medicine that was prescribed? Do you need help getting on to the Zoom tele-appointment that you have? How can we help you to make sure that we are helping the, you know, complete what we started in the office? But, you know, the office is 20 minutes worth of things. That has to go to somebody's whole life. how does that happen? And that's where I see community health workers really excel. To add on to the sustainability and that we know this is needed, so we just make it work. But CMS has made some changes. So as of 1/1/2024, they are changing so that they will pay for community health workers. It is incident to billing, and there has to be an E&M visit and a referral, but we're looking into that so that we can make sure that we can make our program as sustainable as possible, because we all know in rural, like was stated earlier today, we're not here for the money. We're here because this is like our calling. And so we know that rural health systems run on a shoestring budget. And so when we find something really important that we want to make work no matter what, then somehow we've got to get money coming in the door in some way so that we can keep that happening. And hopefully this new CMS ruling will help us be able to get some of that funding back. And then the Medicaid that was talked about, we're looking into that, because basically up to this time we just did it, and now we're like, okay, let's see if we can do it better, because we need more people. We're doing interviews, and if we have more people on the payroll, we do have to have something coming in so we can keep it like that. Nothing's worse than starting a program on a grant and then the grant's over and you're like, okay, that was it, because that's just devastating to the institution, to the community. And so we're not gonna play that game. So
Kim, I love what you have to say. That was wonderful. And it really does give us that, for me, hearing the grassroots work that's being done and how valuable it is. Those anecdotal stories are really important. I want to open it up and have, I really like it when we can ask questions and share amongst each other. So I will do that. And if anyone has a question for Kim, and I know Kelly's still on, if we have any particular questions for the last few minutes, go ahead and just unmute yourself and ask a question.
I have a million different like brainstorms that I think would be really awesome. And I have to shout out Kim, because in my past job as a CHW, I worked with the palliative care team and their population health, and it's a beautiful team. They've always done wonderful things. So I got to throw you under the good bus, Kim. But wouldn't it be cool if they could take the actual true cost the CHW saves, like the Medicare, and give it back to the facilities? Because I know it's not a billable service, but the amount of time we spend, a short amount of time with these people, saving money of them going to the ER or calling the ambulance for non-emergency things that save the taxpayers so much money, but it's not all under one system. So it's not viewed as we're saving dollars, because we're saving the emergency services and the ER, and we're getting people into palliative care, and it'd just be really cool for everybody else to see the value and keep those CHWs around. And if there was a way to show the true savings they create, a system would just be awesome.
I totally agree with all of that, and it's great. Our issue now is the way everything is reimbursed, is that we save all this money. Okay, we save all this money like for the insurance companies, and we keep people out of the ER, but the ER is one of our money makers. So
yeah,
ER, we won't have any money to do anything. And so when we keep people out of the ER, we don't get reimbursed in any other way. It's just like, what is it that we're supposed to be doing? But it's the right thing to do, and it's the only way to take care of patients, correct? So you do it, and then you go, how do we survive if this is how we do things? Hard.
Yeah. It's so hard in this community where we have such a high percentage of fee-for-service. So I know some of the organizations here represented are more into value-based contracting, and that helps a bunch. But when you can't get anyone to come to the table with those contracts and you're stuck in fee for service, right, Kim? It's like, so frustrating. So, okay.
I do need to share one resource for Kim because my CHW brain was kicked in when she said she had trouble with transportation for the kiddo for oncology. There's an awesome organization. I think they're all over, but I think it's based out of Kennewick. I'll drop it in the link. It's called Angel Flights. These are pilots that fly people for free.
We have, yep, we have used that. I don't know what the issue was with this one, other than we might not have found out in time to do anything, because that's sometimes happens, you know, how patients forget that they're supposed to go somewhere until like, oh, I have to be in Seattle tomorrow. But yes, that is an excellent service and we have used them. They're wonderful. Thank you.
Okay. I would like for those of you who, you know, we have just a couple minutes left, and I'd really like to hear from you on what your thoughts are about today's shared learning webinar. And it also gives you an opportunity to say what you want for the future. So if you could go ahead and click on the link to go to the survey, I think it's a MailChimp survey, and complete that, I would greatly appreciate it. And I'm so happy that you all are here today. And were there any more questions? Does anyone have anything else? Okay, I'm not hearing any. So I want to again thank Kelly for coming today and sharing her knowledge with us. And if you guys think of something later that you want to ask, do reach out and just send me an email and I'll get that to Kelly. But everyone else, thank you so much for joining today, and we'll go ahead and wrap up. Next month's webinar is going to be on the 25th. No, the 28th of March at 1 to 2, and you should have already gotten an email invite. Thanks, everybody.